Okay, next up, Dr. Lynne O'Sullivan. Dr. O'Sullivan is an associate professor in the Department of Clinical Studies here at OVC. She holds a Doctor of Veterinary Medicine degree from UPEI, a Doctor of Veterinary Science here from Guelph, and she is board certified in cardiology by the American College of Veterinary Internal Medicine. I've always wanted to say board certified. I'm not really sure why, but she's received many awards for her teaching, including the Canadian Veterinary Medical Association Teacher of the Year Award and a Pfizer Carl J. Norden Distinguished Teacher Award. In addition to her teaching responsibilities at OVC, she has been an active member of the graduate program, supervising or being a committee member for 9 students. She's published numerous papers and scientific conference proceedings, specializing in veterinary medicine, but also in cardiology and broad science journals with collaborators at the U of G and others. She is an expert in natural animal models of heart disease. And her research interests include dilated cardiomyopathy in the Doberman pincer, echocardiographic assessment of systolic and diastolic function, and canine chronic mitral valve disease. Did I get that right? Sort of. It's close enough for government work. The title of her talk is Clinical Cardiac Research, the Doberman Dilated Cardiomyopathy Model.
Okay, good afternoon, everybody, and thank you to Dr. Martino and the group at the CCVI for inviting me to speak today. I'm going to talk about clinical cardiac research here at OVC, and I'm going to start with acknowledgements because this is by no means my deal exclusively. So we have a team of people that support us. So first and foremost, Heidi Chambers here, who runs the Doberman program. Without her, it would not exist. So she's my research technician who organizes all of that. Sherry, who you met this morning, who's my current grad student and resident, who's involved in some of the Doberman research. My colleague, Dr. Fonfara, who's now serves to inspire me and to help along with this research as well. I have numerous collaborators, as you will see in some of the things that I'm presenting. So again, this is by no means exclusively my work. And I think that's something that has strengthened my research program greatly. I've worked with a lot of DVM and other undergrad students, so I have to credit them. Of course, the Dobermans and the Doberman owners. They have given a lot of their time and efforts to this program. In particular, I just want to give a shout out to Leanne Stalker, who provided a lot of photos that you will see for my talk. The OVC Pet Trust, who has sponsored a great deal of my research. I thank them greatly. My lab is the hospital. Okay, so I don't have a lab, so to speak, in the traditional sense of the word. My lab is the hospital. I'm a clinician. And again, I liked this quote. I think this sort of embodies my research philosophy, which is, again, I find it hard to achieve something great by myself, but with a team and with collaboration, we actually can achieve some great things. Much like the Ontario Veterinary College has a very rich history, the Doberman program actually has a history that predates me as well. So again, I have to give credit where credit is due, and that is my former colleague, my mentor, my trainer, Dr. Mike O'Grady, who is now retired, started this program over 30 years ago. And then I, being one of his grad students, his resident, naturally my research was in Doberman dilated cardiomyopathy as well. And then when he retired, I inherited the program, like it or not. And I've kind of kept up with it, or at least tried to do it some justice. So here's how I sort of see the program and what it has given me. So we have this clinical screening program here in the center. Again, I'm a clinician, I see patients, and so we see Doberman pinschers from the time they're 2 years of age yearly to screen them for this disease that I'm going to talk about. And that provides, obviously, this sort of naturally occurring model of disease. I don't have to create it in zebrafish or anything else. It just happens, unfortunately. And then that provides a population from which we can study all sorts of different aspects of the disease. So I'll talk a little bit about some sort of observational studies on the natural history that we've done. We're interested in diagnostic imaging. You know, that's one of the main tools we use to find the disease. So different studies to look at new diagnostic imaging tools. Biomarkers, you know, here's an area where we can investigate the utility of certain biomarkers in diagnosing or prognosticating. We've been involved in a number of pharmacologic clinical trials, so I'll allude to some of those. And then I think most recently, with a fantastic team here, I've had the opportunity to collaborate and utilize the skills that I do not have. So myofilament function, which is something that, you know, Dr. Glenn Pyle's lab can provide, genetics, which is not my forte, microRNAs, which is perhaps one of Tammy Martino's areas. We are now collaborating on some projects because we have these people in our own midst. So I'll talk a little bit about dilated cardiomyopathy in general. And Dr. Dawson already alluded to this a little bit. So this is a primary myocardial disease that is characterized principally by systolic dysfunction. Okay, so a lack of contractility of the left ventricle, possibly also the right. And the heart's response to that is that it dilates. And I just want to emphasize that this is an inherent myocardial disease that is not secondary to some of the other common diseases, like in people, coronary artery disease, a valvular problem, you know, pericardial disease, systemic hypertension. This is an intrinsic disease, and I'll allude to some of the causes, but we're not talking just the response of the heart to, say, a myocardial infarct. This is an intrinsic myocardial disease that patients may be predisposed to. And in the canine world, here's a list of some of the causes. Genetic, obviously, in our purebred dogs is going to be a big player here, and I'll talk a little bit about that. Tachycardia induced, what that means is if you make the heart beat fast enough, its response will be to develop systolic dysfunction and fail. And you've probably been aware of pacing-induced heart failure models in some of the literature you've read. So that's what that's all about. Some toxicities can cause this disease. Notably some chemotherapeutic agents, so that's a problem in some of our chemo patients. Infectious causes. In southern US and in South America, there's a disease called Chagas disease, and it's a little protozoan parasite that can be associated with a morphologic diagnosis of dilated cardiomyopathy, not something we see here. We wonder if perhaps viral diseases may be associated with DCM. It's certainly prevalent in people. And then finally, when we can't necessarily identify a distinct underlying cause and we don't know the genetics in a particular dog, then idiopathic means we just don't have a specific cause. And that's actually quite frequent in our patient population. The Doberman is unique in that this breed experiences a very high prevalence. So a lifetime incidence of 45 to 60%, depending on geography. So a very high percentage of these dogs may develop this disease. And it's quite devastating because a quarter to a third of these dogs may experience sudden cardiac death as the first sign that they have the disease, and that's obviously not good. If they do experience congestive heart failure as a result of this disease, their prognosis is really quite poor, and it's kind of more poor relative to some other dog breeds. I'll touch really briefly on genetics because it's certainly not my forte, but this is just to alert you to the fact that, yes, we know it's genetic in the Doberman breed. You know, the inheritance pattern has been described, so it's autosomal dominant with incomplete penetrance, meaning just because you have the genotype doesn't automatically mean you're going to express the phenotype. There are other influencing genes or environmental factors or things that are going to determine whether an individual expresses the phenotype. And there is at least one identified genetic mutation to date. The Muir's lab at North Carolina State are the most active, I would say, in this area. And they've identified a mutation in the PDK4 gene that's associated with DCM in the Doberman. They've potentially identified a second gene, but we don't really have any details yet on what that is. And then a European group suggests that there may be some other gene in their Doberman population that is responsible for this disease. And you might recognize this guy. So this was our attempt, and maybe naive, I don't know, a naive attempt at sort of a needle in the haystack approach where we targeted some of the genes that are involved in DCM in humans and went looking, do any of these have any association with Doberman cardiomyopathy? So here's a list of the genes that we went looking for, and we didn't come up with any mutations in the coding regions associated with DCM in the Doberman pinscher. And that's kind of the extent of my experience with the genetics so far. Not to say we won't delve back there again sometime. So this disease, clinically, in the Doberman, sort of presents in two forms. So there's the typical morphologic form. I might just try, I don't know if lights can, am I just going to mess things up? It's just a little bit better for the imaging. So the classic presentation is, again, the dilated weak heart. And so that's sort of what this ultrasound image is showing. We have a left atrium, a left ventricle, and the walls of that left ventricle are really not moving very well. And so that's the characteristic presentation. Some dogs, however, present with ventricular tachyarrhythmias. So here's an ECG, here's our normal beats, and then we have this cluster of ventricular premature contractions, ventricular tachycardia. And so some of them present with arrhythmias, and some of them have both. And so we know now that sort of these are the different clinical presentations we see. You know, are these different manifestations of the same disease? Are these somehow different diseases? There's a lot of questions that we still have about this. Just to compare and contrast a little bit with human dilated cardiomyopathy, as Dr. Dawson alluded to, DCM is the most common cardiomyopathy, sorry, HCM, and it's actually the third most common heart disease. It certainly takes a back seat to coronary artery disease, and it affects, you know, a fair number of individuals with a significant mortality rate, and it is absolutely the leading cause of cardiac transplantation. Etiologies, you can see the list looks somewhat similar to what I alluded to in dogs, and I'll touch a little bit on genetics, but there's some of the same players in people as we appreciate in dogs. Regarding the genetic forms or the familial forms, the literature would suggest that roughly 30 to 50% of cases of DCM in people are familial or related to an inherited genetic mutation. And there are now hundreds of mutations in more than 40 genes identified in different families. So a vast array of mutations, and I've circled, you know, a whole bunch of proteins in this complex diagram. Where's actin? It's in there. Yeah, it's circled. So it is one of the players, and so it's quite complex in terms of all the different mutations that have been identified in people, and we only are in the infancy of really understanding the genetics in dogs. So again, here's the epicenter, you know, the Doberman screening program, and I'll just talk a little bit about some natural history work that we did sort of in my early career. And this timeline is just to present, okay, what do we know about how this disease progresses? We know that dogs, you know, so-called stage A that's a normal dog, okay? And then we screen them yearly, and at some point in time, we identify a clinical marker that says that they're an affected dog. So stage B1 means we have identified something, and it's typically either systolic dysfunction or an arrhythmia that tells us this is potentially affected dog. And then their heart progressively dilates over time, and they become a stage B2. This, by the way, is a staging system that's used in people as well. So they develop the progressive cardiac dilation, and these factors place them at risk either of sudden death in the preclinical phase. Okay, so they're still asymptomatic in this phase, but they have cardiac dilation. They may experience sudden cardiac death, or alternatively, they may develop clinical signs of heart failure and kind of transition over into stage C. And then stage D is sort of the refractory heart failure patient. And these dogs, once they're in heart failure, again, they may die from heart failure. Owners may choose to euthanize them once their quality of life is poor, or alternatively, they may experience sudden death after the onset of heart failure. And so in terms of this is sort of what we know, but there's a lot that we don't know in here. And we don't know a lot about sort of what exactly is going on during this progression here in the preclinical phase. And I think that was something that we were rather interested in, and we've been trying to peck away at a little bit. So one thing that we did was look at could we examine the records of all these Dobermans that we have been evaluating over the years and describe some clinical findings and outcomes in this population and determine if there's any sort of predictors of congestive heart failure or sudden death beyond the obvious? And so we looked at records from 163 dogs, and I'm just showing you a few simple findings here. And one of the first conclusions we probably erroneously had was that males were affected more than females. And I think that stems from how we define the disease. So we know now that females might tend to present with the arrhythmic form more than the dilated form. The males present earlier with the dilated form. We also found that, okay, the average age of onset was about 7 years old, which is actually a little bit late compared to some other breeds. But we had dogs that were very young and very old, too, in terms of when they developed the disease. When we looked at from the time they were diagnosed, what sort of timeline did they have before they were in either congestive heart failure or experienced sudden death? And we found that that timeline, average and median, was something on the order of 1 to 1.5 years. And it seemed like the group that experienced congestive heart failure versus the group that experienced sudden cardiac death, there really wasn't a difference in that time frame or the time to that outcome. So again, just a few select findings. We thought originally males were overrepresented, but again, I think that's sort of been disproven by now. The average age was quite middle-aged, but a chunk of them were actually less than 5, and a chunk of them were rather old. As a clinician, it was interesting to me that 28% had absolutely no abnormalities on a physical examination. So the only way we found them was by actively screening them. And these were, again, asymptomatic dogs with no reported abnormalities by their owners. Average time to heart failure or sudden death was about 1.5 years, and it didn't seem to matter whether the outcome was heart failure or sudden death as to that timeline. 1/3, here's where we determined, 1/3 experienced sudden cardiac death as their first clinical sign. So that was quite alarming. And those particular dogs were more likely, and this is maybe not surprising, more likely to have more identifiable arrhythmia on their baseline ECG. It made sense. And then this was also an attempt to look at, well, are there any predictors of time to outcome? And we thought that certainly the amount of arrhythmia on ECG, interestingly, their heart murmur intensity on auscultation, their left ventricular wall thickness, and the diameter of their ventricle in systole indexed to their body weight seemed to play some role in predicting that timeline. And this was our first indication that maybe therapy with a class of drug called an ACE inhibitor may delay the onset of congestive heart failure or sudden death. And again, this was retrospective, so maybe a little clue that may or may not be true. Which then leads me to some of the clinical trials that we've been involved in, the pharmacologic clinical trials. Can we make an impact? So just bringing you back to this timeline again, or this progression, can we make an impact in this preclinical phase? There's a prime opportunity to make an impact in slowing the progression of disease. And we wondered again about the role of ACE inhibitors. So here's a schematic, a cascade showing us the RAS system. You're probably all familiar with this. So we know that within the cascade, angiotensin II is certainly a big player in negative myocardial remodeling in terms of the progression of this disease. So by using an ACE enzyme inhibitor, that is to inhibit the production of angiotensin II, might that prove beneficial? And so once again, this was a retrospective study, so not the highest level of evidence, but we went looking, if dogs were treated with benazepril, which is an ACE inhibitor, did that delay progression of their preclinical DCM? And what we found is that dogs that received an ACE inhibitor, which is the solid line here, these are survival curves, so proportion remaining preclinical versus time. The non-ACE inhibitor group are the little dotted lines here, and we did find that an ACE inhibitor seemed to prolong that asymptomatic phase, which from an owner's perspective I think is valuable. So we did find in 91 dogs, by the way, that the time to heart failure or sudden death was 25 to 28% longer in the group that got benazepril. There's a plethora of evidence that ACE inhibitors are useful in preclinical DCM in humans, and so this was something we really wanted to show, and and demonstrate, and it has changed certainly the way that I treat them. Another medical therapy that we thought about as well is positive inotropes. So if the fundamental abnormality here is a reduction in contractility, is there something that we can administer to improve that contractility and impact on their outcome? And we already had a drug on the market, Pymabendan, that was already licensed for the use for treatment of congestive heart failure due to this disease. What we didn't know was whether, if we started that medication earlier in the preclinical phase, could we actually prolong that preclinical phase? Again, importantly, helping these dogs have a lengthier time without symptoms. And so we had an opportunity then to participate in this multi-center clinical trial. So this is a group of people that come from various centers. And again, I certainly can't take credit for the design of this trial. I was an active participant, but it was certainly not my brainchild. And this group of investigators assembled to design a study that could answer the question, does Pymabendan delay the onset of congestive heart failure or sudden death in the preclinical phase? The design was prospective now, so not retrospective like the past study I showed you, but prospective, randomized, multi-center, United States, UK, and Canada, and placebo-controlled, and we enrolled 76 dogs, 20 of which were at this center here at the OVC. And what we were able to demonstrate is that the group that received Pymabendan, which is this solid line, indeed had a markedly prolonged preclinical phase, 718 days versus 441 days for the dogs that did not receive Pymabendan. And this was the first clinical study in veterinary medicine to demonstrate the efficacy of a medication in the preclinical phase of any cardiac disease. And now, again, this changes the way we treat these dogs, and now we're looking at, does this medication benefit other breeds with DCM as well? And then the last little clinical trial that I'll talk about is something we're working on right now. So within this RAS cascade, we know aldosterone is one of the end products. Aldosterone, like angiotensin II, is also a contributor to negative myocardial remodeling. It's pro-fibrotic, and so we do wonder, what if we administer a mineralocorticoid receptor blockade, which will more completely block aldosterone? Can we have an impact again on their morbidity or mortality? And we know from some human trials, the Rails trial, which was a pivotal trial in people, spironolactone, which is an aldosterone blocker, was effective in reducing morbidity and mortality in humans with heart failure. So I'll just introduce this trial, which is spironolactone and Doberman pinschers with congestive heart failure. It is a prospective randomized placebo-controlled trial. Andrew Lascari is a biomedical sciences student who has been assembling all the data for this. And he's been working over the past 2 semesters doing that and getting the stats done. And so very briefly, our objectives are to determine whether spironolactone has any effect on their survival time. That's the primary endpoint. Secondarily, we wanted to see, does it have any impact on their clinical parameters? So again, it's prospective, was prospective because the trial is done. It was randomized, single-blinded, placebo-controlled. We enrolled 67 Doberman pinschers over a long period of time. The groups were roughly equal for placebo versus spironolactone, and these dogs were receiving other standard therapies equally. Okay, so they were on their own, all the standard therapy equally. And our primary endpoint was cardiac death. Secondary endpoints were other clinical parameters. And I'll just share with you really quickly 2 findings. Here's our survival curves, which, they want to diverge, maybe a little bit. And here just shows you the abysmal survival times of these dogs once they reach congestive heart failure. 180 days is sort of what we're achieving from the time of heart failure start to cardiac death. And maybe spironolactone has no effect here. Maybe this is real, no effect. On the other hand, maybe we were just unpowered to find that change. Because when we look at a multivariable model, trying to control for other things that might have impacted their outcome, it appeared that spironolactone actually does have a protective effect here in our risk ratio. So we're examining this more closely. We've got some more work to do. One really interesting finding was that, interestingly, In the spironolactone group, there was a far less prevalence of a rhythm called atrial fibrillation that developed in that group relative to the placebo group. So 45% versus 20%, which was significant. And atrial fibrillation development is a really poor prognostic indicator. So is it possible that the antifibrotic effects of spironolactone might be having a positive influence on the development of atrial fibrillation, which would be really nice. So more work to be done there. Finally, I'll just touch on a little study that we're working on that involves some imaging and some biomarker work. And this is Dr. Rahab's project. And so this is looking at a hormone called NT-proBNP. And we're also looking at some imaging, specifically something called strain imaging. And we are doing this in preclinical Dobermans. Okay? So N-terminal protype B-type natriuretic peptide is a hormone elicited by myocytes. And it's increased excretion from these myocytes under conditions of stress or stretch. And what happens is there's a precursor hormone that is intramyocardial, and then it's released into circulation, cleaved in circulation into the active BMP hormone, and then there's this little inactive N-terminal proBNP fragment. And the assay will measure this fragment because it's more stable in circulation, longer than the active hormone. We already have data that shows that this hormone may have a role to play in detection of subclinical disease and in differentiation of heart failure from respiratory disease, which is important from a clinician's standpoint. What we don't really know, we don't have a lot of data on, is the potential for this hormone to help us with therapeutic monitoring or the potential for this hormone to predict prognosis. The other aspect of this project that we're looking at is something called strain imaging, and it's using a technology called Speckle tracking. And what we can think about is that strain, an object undergoes strain if all portions of that object are not moving at the same speed. So if all portions of an object are moving at the same speed, it does not undergo any deformation or strain. If things, I should say portions of that object are moving at different speeds, that object will undergo deformation. And a heart most certainly undergoes deformation. And so how is it defined mathematically? It's the change in length of a myofiber divided by the original length. And what we can do with a standard two-dimensional image of a heart, so here's our left ventricle, the principle of cardiac ultrasound is that that tissue is generating these acoustic markers or speckles, all those little gray, white, black dots that you're seeing. And what machines of today can now do is track those speckles from frame to frame. And so if the machine can track a particular acoustic marker from one frame to another, it can actually then use probably a very complex algorithm to calculate strain. And so this is called strain by something called speckle tracking. And so that's what we're looking to examine in our Dobermans. And here's our objectives. We want to take this group of preclinical DCM patients and follow them over time, track their BMP hormone, and also look at strain imaging over time in these patients. And really what we want to know is, can we describe sort of how these things are changing over time, and does it help us clinically predict when this patient may be at risk of heart failure or sudden death? So our hypotheses are sort of just as I mentioned. We predict that their BMPs probably rise over time, and we're wondering, do their strain parameters change over time, worsen over time? And I'm particularly interested in knowing the ones that have just the arrhythmic form. What do those guys do versus the one that have the more classic dilated weak form? And we want to know whether, again, this has predictive value. So we've enrolled 20 dogs to date, and that was sort of our target. So in the first year, we've enrolled 20 dogs. We're examining them every 3 to 4 months, and we're collecting this data. We're collecting the strain imaging data and the BMP hormone. And we plan on following them until their outcome or until the end of the study, which is maybe 3 years down the road when Sherry's project finishes. And I'll just show you one slide to finish, which is a radial strain output of our ultrasound machine. So here we have a short axis view of the left ventricle. And really, what we have to do is we just take this image, we trace our region of interest, so we define for the machine where's the endocardium, where's the epicardium, here's all the heart muscle in between. And then what that machine does is then track the speckles within that cycle and will graph, both in a color format and in a graphical format, peak strain over time. And so the dark red color right in the middle here represents peak systolic strain. The green line superimposed on top is aortic valve closure. So we can kind of see that things are happening very synchronously here. And these different colored lines represent strain from the different myocardial segments. The machine automatically cuts this circumference into 6 myocardial segments. And then it graphs the strain for each of those segments. And this is something that we are just getting into now. We're just learning how to use this. We made a visit to the Sick Kids Hospital to see what they're doing. And what we're finding is in some of our dogs so far, we know that their strains are tending to peak later. So it's later to peak. We're also finding that there's potentially diminished strain in some of our dogs, not surprising. But this is sort of the data that we're going to be investigating, and we have a long way to go before we have any results to present. That was just my hypothesis slide. So this, I think, again, in a nutshell, represents our program. Lots of opportunities to collaborate, hopefully, with folks. I hope I didn't bore you, but rather maybe inspired you to come talk to us.